evening, everyone. My name is Cristina Hernandez, and I'm a Health Justice Fellow in the Social Mission Alliance, currently in PA school at ATC University. Just so everybody knows, we will be recording this session for those that couldn't attend. It is my honor to welcome you all to our second webinar and event of the semester. But before we start, I want to orient you all to the purpose of the Social Mission Alliance and the Student Assembly. To the Social Mission Alliance, formerly known as Beyond Flexer, is focused on the health equity and training health professionals as agents and more equitable healthcare. This takes us beyond centuries-old conventions to train providers prepared to build a system that is not only better, but fairer. The Alliance is dedicated to realizing the health professional education system that is responsive to the issues preventing our countries more vulnerable from realizing their full health potential and accountable to the needs of those oppressed in these oppressed communities. That is how social mission is, the contribution of health professional schools in its missions, programs, and the performance of its graduates, faculty, and leadership in advancing health equity and addressing the health disparities of the societies in which it exists. The Alliance has been a space for committed educators and leaders to exchange the best practices in collective effort to advance social mission across the country. The Student Assembly was created to serve as an interdisciplinary forum dedicated to elevating the perspectives of those experiencing the health professional and education system, while acknowledging the learners that have always had a place in the struggles for a more social, accountable, and just education system. This is what brought me to the Social Mission Alliance as a health justice fellow and has inspired our discussions for tonight. As a student, former undocumented immigrant, and a low socioeconomic background, applying to college and then to PA school, I have witnessed the promises that institutional representatives have made describing inclusive and supportive training programs where people like me could thrive. I've always seen these promises fall short, and I actually experienced as I and many other students with similar oppressed identities from low socioeconomic income backgrounds have struggled to even survive in the training process. As we march forward in our training, we're always so focused in survival that we may not even notice those classmates who don't even make it to the clerkships, those whose names are recalled at graduation. Tonight, we'll talk about this war of attrition, where students like me are the ones the least likely to make it to graduation, and examples of initiatives that are working to move the needle. It is my honor to introduce our moderators for tonight's event, Mytien Nguyen. Mytien is an MD PhD student in the Department of Immunology at Yale School of Medicine. Mytien is a biracial Vietnamese Black first-generation college student, graduate. She obtained her undergraduate and master's degree at Cornell University studying microbiology and bioengineering. She's passionate about advocating for socioeconomic diversity in STEM and medicine. Growing up as a low-income refugee, Mytien fully intends to utilize her platform as a STEM and health advocate to uplift the voices of oppressed and advocate for these oppressed minorities communities. Okay, thank you, man.
Thank you, Christina. Good evening, everyone. Thank you for joining us tonight on a very important topic and conversation. I'm so happy. I'm going to try to sound a little bit chipper than usual, because this topic is a little bit sad, or a lot of it sad, and triggering. And I want to acknowledge that in the beginning. And so I'm also very excited to introduce our panelists today. And before the introduction, I want to share some thoughts on attrition, or, as Christina said, the loss of human capital as we navigate through medicine and the healthcare workforce. So attrition, or losing trainees, people, and critical healthcare workforce individuals exacerbate the current critical shortage of healthcare workers that we have in the United States. Then that also exacerbate the current barrier to reaching our health equity goals. Therefore, in order to address this health workers shortages and also plan effectively for the future, for a bright future where we have health equity, more focus is needed in order to be needed and dedicated to the issue of attrition from healthcare workforce. And high level of attrition is a huge loss to the system in terms of there's losses to public services spent on training and education of these health workers, trainees, as well as attrition also contributes to this increase in workload and the worsening conditioning for the remaining workforce who stays within the workforce and the training itself, which in turn contribute to lower quality of care and worse health outcomes, especially for underserved communities.
She's here in a minute.
Please also mute yourself. Thank you so much. However, as Christina has alluded to, attrition from the healthcare workforce is not equitable across identities. Previous studies have shown that students and trainees from marginalized identities, including all Black, African-American, Latinx, and Indigenous trainees, as well as trainees from low-income backgrounds, have the highest rate of attrition from medical school. These disparity in attrition alarmingly parallels and mirrors the public health disparity we see in our patients, where patients from underserved communities are facing the greatest health inequity. We found that trainees who grew up in these same under-resourced communities are also leaving medical school at higher rates than their peers. Therefore, attrition of marginalized trainees then perpetuates this health inequities experienced by under-resourced communities. So the very critical question of attrition is why? Marginalized students are more often to have negative experiences during the trainee than their white, their male, and their high-income peers. They report higher rates of mistreatment, microaggression, as well as discrimination. Prior studies have shown that these students who report higher rates of mistreatment and discrimination are subsequently more likely to leave medical school. So in today's panel, we really hope to engage in an open and honest conversation about attrition and the cost that it has to the healthcare system and across the health professions. And I'm really excited and honored to introduce our amazing panelists today. And so to start off, we have the amazing Diana Martinez. Diana is a freedom dreamer, a public health practitioner, educator, and thought leader within health equity and social and racial justice with over 17 years of experiences within academia, policy, and community-based work. Diana is the founding director of the Learning Environment Office at the University of New Mexico School of Medicine, which was launched under her leadership in 2019. Diana has brought public health system transformation and equity framework to the Learning Environment Office's mission, which is to foster an inclusive learning environment where teachers, staff, and learners thrive, where relationships are mutually respectful and beneficial to each other and to institutional climate. Since its launch, the LEO has grown from a team of 4 to 12, including staff and faculty, making it one of the most robustly resourced offices of its kind. Diana is currently completing her doctorate in public health at Johns Hopkins University with a concentration in health equity and social justice. And then we also have the amazing Dr. Howard Straker. Dr. Straker has more than 30 years of PA educational and clinical experience and is an assistant professor in the physician assistant program at George Washington University School of Medicine and Health Sciences. Dr. Straker serves as the director of the PA and PH program, coordinating the joint degree curriculum across the PA program, and 4 departments within the Milken Institute School of Public Health. He teaches in both the Department of Physician Scientist Studies and the Department of Prevention and Community Health. Dr. Straker's interests are in the preparation of practitioners to work in underserved communities, diversity and inclusion, health professions workforce, and blended learning pedagogy. Dr. Straker is the past president of the Physician Assistant Education Association Board of Directors. And last but not least, Dr. Patricia Coleman-Burns. Dr. Coleman-Burns is the Assistant Professor Emerita at the University of Michigan School of Nursing. As a scholar, Professor Coleman-Burns has focused her career on retention and successful learning behavior of underrepresented nursing students, health disparity and social justice in patient care and providers' behavior. She's also focused on Black ideology and the Colored Women's Club movement. She is an advocate for the rights of all persons to be free from gender oppression, sexism, racism, and violence. She has served as the co-chairman of the University of Michigan's Violence Against Women Task Force, as well as serving on several advisory committees on diversity, multicultural, and women's issues. She serves on the executive board of Safe Health Center, which provides services for those impacted by domestic violence and sexual assault. Her research is on racial identity and the reduction of health disparities. So that concludes our panelists for today, and I'm so excited to welcome everyone. Before I proceed with my first question, everyone, please, as questions comes up, please input them onto the chat. I'll be monitoring the chat for questions as well. And without further ado, let's hear from our panelists. So thank you for joining us, Dr. Straker, Dr. Coleman-Burns, and Deanna. So what does attrition mean to you? And what do you think is the cause of attrition? And I'll have Deanna start, if that's okay, since you're nodding a lot.
Sure. Well, hi, buenas tardes, good evening. I just want to first start by thanking y'all and the organizers for the invitation and just sharing your time. For those of you on the East Coast, I'm in Albuquerque, so it's like reasonable hour, y'all. It's like my bedtime. So I am especially thankful for you being here. You know, when I think about attrition, I think, I guess, about a couple of different ways that this happens. And we talked a little bit about this, you know, in the introductions, but really thinking about like forced dismissal and like forced withdrawal, right? So I think folks can be dismissed because they're not, you know, like meeting academic or professional standards or expectations. And I think, you know, like about this term, I'll offer this term of like forced withdrawal as a way to really challenge the assimilation that's expected to occur during higher and professional education, right? So like, if we don't look like you, if we don't talk like you, we're scary, we're probably a little threatening, perhaps deemed unprofessional, right? And so, you know, I think about like this forced withdrawal is really like through the culture and climate of institutions. You know, so it's students of color, queer, women, LGBTQ students who are most likely, as already discussed, like to be mistreated, harassed, and discriminated against, and not even like in the most obvious or like overt ways, right? But like what can be like seemingly innocuous or you know, like covert slights that are really extremely harmful. And we know that from, you know, like microaggression, the true effect is really the cumulative impact, right? It's the harm is multiplicative. And so I think that the result of that culture can be different for each individual. You know, maybe our studies decline, maybe we're dismissed because of that. Maybe we begin to doubt ourselves and like, do we even belong here? Or maybe we're just too tired, right? And like when we're just done, we quit. So, and you know, to respond, I guess, to your second question, I'll just perhaps take like the real macro view in that, you know, like I think the cause is really white supremacist, heteronormative, patriarchal capitalist systems and its effects.
Thank you, Deanna. And Dr. Coleman-Burns, Dr. Straker, thoughts on what does attrition mean to you?
Well, let's talk about what it looks like. You all are, and thank you so much for inviting me. Thank you, Dan, and all of the people who are in our audience, all under the same name, but I think some of those folk are coming from my community. I see my daughter-in-law there. So what does attrition look like? This past January, we did, University of Michigan has one of the largest celebrations of the Reverend Dr. Martin Luther King, dozens of events. And the health sciences come together to do one. And so this year, dentistry led. And I was very impressed by a question that a young a PhD dental student, I think in his last year, raised as we were talking about recruitment and these issues of retention. And he raised Dr. King's quote, where Dr. King says, after all these years, I'm beginning to have doubts about encouraging young people to integrate into a burning house. And so this dental student at the University of Michigan Dental School is saying, so what are you all doing? You keep trying to recruit us. You're recruiting us into this burning house. And whereas I certainly embrace that, I agree. And we talked about, and I'll talk later about white supremacy ideation, the notion of a culture and a profession that is predominantly centered by white identified people, whatever that may be. But I had to say to this young man that this has been our efforts, and you here represent that, to change the house, to create and build a new foundation, a new house that encourages and meets the needs not only of you who are studying in your profession, but to meet the needs of our people who have healthcare issues. That this toxicity that we can experience in professional education is also perpetrated on the patients that we serve. And so the two are connected to each other. And so I certainly think that what we have to do, and so good to see young people there. Yes, your mom, I hope that's your mom or your sister, is doing an amazing job. And we just want to say that we are recruiting you into something that has been historically challenging, unaffirming, dismissive, as Diana talked about, where most of the students that I've worked with for very many years, they'll say, yes, it's a horrible experience, but once we navigate it, once we learn how to negotiate it, we are stronger. And so I'll stop, but we can talk about those who have made it through, like you, and those who have had and maintained your own integrity, your own value of who you are, and are then able to stand up. Maybe I might slip in one more, if I don't know, Dr. Howard, because I wanted to start with the example of a student like one of you. She wasn't supposed to be the top student. She was, or maybe he was. And so, at the end of graduation, how you stand up, and all those who have 3.0 and above, stand up. Those who are 3.5 and above. And so the crowd shrinks. She was the last one standing. And people couldn't believe she was a Black woman. But when I checked up on talking about attrition, not only in school, but as your professions. So I checked up on her later. And because of some of the systemic ways in which underrepresented students have to deal with, she was placed in one of the lowest resource institutions, could not get employment in one of the top ranking hospitals. And when I checked on her, she said, Dr. Coleman-Burns, they call me PCB. She said, this is the worst experience I ever had. I don't know why I got into this profession. You all taught us integrity and ethics, being the best discipline, and then we have to go serve in a place, in an institution, a hospital that does not value who we are, that has no resources, because most of us who have federal loans, for example, can only pay those off by spending 2 years straight out of your profession in the lowest, in what they call health professional shortage areas. And you know what that means, no resources. People who don't want to be there. It's the worst thing to do to people that we're trying to prepare for the future. I'll stop there.
Well, thank you, Dr. Coleman-Burns and Deanna Martinez. First of all, thank everyone involved. Thank you for inviting me. I think this is an extremely important topic. Right now, there's a lot of energy on diversity and inclusion, which usually translates into coming in, recruitment. And the way I look at attrition, you know, using the house analogy, we come in the house through the front door, and attrition, you go out in the back door. You don't leave the front door like everyone else when it's graduation time. And, you know, this is a reflection of us being in a society that's built upon, you know, inequities, you know, and those inequities are, you know, racism is a key one, but it's classism, it's around gender, it's part of a capitalist system. And when we think about those structures that make that happen, education has been one. And it started before we even get to health professions education. So when we really think about it, the higher you go in the educational system, the more it's a weeding out system. The more it's really designed that if you're going to end up in the top, then you're probably going to look like the people who designed the system. And they wanted people like them. It's an issue of power. It's an issue of control and privilege. And so a lot of us aren't supposed to be here, and it's designed that way. And what we have to realize is the structures that have been built upon over years. So they're little things, sometimes they're small things within the course of a program that actually causes it to kind of, even people's well-meaning, they end up following the system that allows it to say, hey, you don't belong here. And that ends up being either that people get academically dismissed or they withdraw. I see those as signs of injustice. I see those as part. It's kind of hard to study when you've got all these other things going on. It's hard to study when people around you you can see discrimination happening, or people are abusing either you or people like you. It's hard to study when people back home are getting killed in different ways, in multiple ways, or when you don't have money. And the system is not designed to care about how you feel. They just, you know, people focus on grades on a test. And even the test and testing in itself is an inequitable system. So it really isn't designed in a way that that necessarily supports other folks other than the ones who have the resources to be weeded in, as opposed to those who get weeded out. So I think there's been a lot of energy and a lot of attention on diversity. And just like that person who talked about coming to the burning house, and not enough energy has been put on how do we keep people, how do we help people navigate through the systems so they can go, and how do we rebuild the system? And that's what I think our energy needs to take place. When I think about attrition, that's what I think.
Thank you. I want to follow up on all of that. It was great thoughts, and thank you for sharing the stories. In terms of setting, and this has been alluded to in everyone's answer and responses is this idea of setting students or marginalized students up for failure in a burning house. What are these structures that are, setting students to fail, especially, low income, Black, Indigenous, Latinx students from under-resourced neighborhoods, et cetera. What are these structures, and how do these structures, current structure, manifest and leads to attrition? And I'll also add on to that as well. How does that impact the community as well, and the cost of attrition?
I'll start this time. I think there's a lot of structures, and I know we've been looking in our institution at what are the various structures. I can tell you that one of those structures, at least in terms, when I think about PA education, a lot of them are really designed from the old traditional way of learning, which was you give people a lecture and you give them a test, okay? And most of our people did not necessarily learn that way in our communities, right? But that lecture and that test is what is all that really counts. And if you can't hang for the test, you don't belong here. And so I think that it's as simple and sometimes as just, is that even the best way to learn? Education will tell you that is not the best way to learn, but a lot of us have structures that only have one avenue, one way to teach, one way to learn, one way for that. And so that begins in there. Other things are simple things like if you're in graduate school and you need a GPA of 3.0 to stay off of probation or to keep moving forward. But we're all in these health professions that are competency-based. Why do we have grades to start with? If you pass, you pass, right? If you meet the competency, that's where it can be. But we're stuck in these formats of that. If you have grades and they're built on how many hours you spend in a class, then I'll tell you, my program has a 7-credit course in the fall and the spring. That is a huge obstacle, because if you get a C, which means you've passed, you have now jeopardized your GPA and you could be put on probation and ultimately you could get put out for it. Why can't we split it up? Why can't we take away the grade? So that's one of the struggles in terms of just those structures. There are other structures. I'm going to give other people a chance to talk about some of the other structures that exist, but I think it's things like that we don't think about, and good meaning people think that, well, that's the way it is and you just got to do it, and I'm willing to help you even though they don't know how, but you just have to meet that and everything will be fine. So, yeah.
I have 2 examples around the question. The first is the culture. How do you give and equip students with the tools to be successful when they have values that are anti what the status quo is? So often that whole idea about you can't get a C, I would have students who would say, oh, Dr. Coleman-Burns, I didn't study hard enough. No, that wasn't the problem. They keep studying because they didn't know how to study whatever that system was. And so because they valued stick-to-itiveness, instead of dropping the class, reorganizing and coming back later, they would fail the class. If you fail 2, you're out of the program. So not only, and I can talk later about it in a program that I did in Genesis, I gave them from the beginning peer facilitated study groups. So they were these were not remediation. These were how to be successful in this program from day one around the difficult courses, pharmacology, anatomy and physiology, pathophys. So there's a sense of understanding the cultures that our students come and the values they have, not asking them to change their values, but to at least recognize that the house's values have to be navigated around. The second thing is that these are clinical professions. And so preceptorship is extremely important. And the second example I have, I had a student who was a master's prepared student, and he was going for his nurse practitioner degree. And so, as you well know, these different roles, or if you don't know, nursing has, the basic generalist role of a basic RN or BSN, and then masters can be more specialties, but nurse practitioners, like my daughter-in-law, they have their primary care, they have their own clients within, depending on what's going on in the state. So he was a master's prepared nurse with a specialty, seeking to get his degree as a nurse practitioner. But because of implicit bias, because he was a Black man, and because he was from an African continent, his preceptor seemingly was afraid of him and would send him in to take care of his patients, never monitoring him, never educating the difference between giving it specialty care and taking on the care, the total care of one's patient. So she was never in there. So what did he do? He gave his patient the care that a master's prepared nurse would do. Guess what? They wanted to fail him because he did not meet the criteria of a nurse practitioner. So the biases that are built in are often harmful to our students because they don't get the mentoring and the preceptorship that they need, that people are either afraid of them or feel that, oh, they're not going to do well anyway, and simply don't intervene in the progression and development of these students and then fail them. So that's a good way, in other words, a bad way to treat people. And so, solutions are making sure that students are treated fairly and equitably, and that the faculty and the preceptors have the qualifications to deal with a changing workforce and a changing population and all the needs to reduce health disparities. And we can talk more about that later.
Thank you for sharing. Those are such deep examples, right? And that, it's reminding me again of just the cumulative impact. And it's not just one thing that happens. Specific to the work that we've been doing around addressing mistreatment, I'm reminded of the concept or saying of hurt people hurt people. And that's, part of what we see so much in, when it comes to mistreatment or harassment or discrimination, and is chalked up a little bit to be this oh, that's the culture of medicine. That it's just you have to hack that. And if you can't, then you're not meant. And and it's just becomes then this cycle of mistreatment and cycle of harm. And where are we, trying to kind of stop and be intentional about how can we heal people so that way, they can do the work to see I'm not a great doctor or nurse or whatever because I went through this particular system and because I was mistreated, right? I am good at my profession despite that. And how can I change? So I think also you asked about cost, or maybe we are not there yet. Maybe I'm skipping ahead. I apologize.
We can transition to cost as well. And I just love, there's so many different aspects, and we can kind of summarize in terms of see that the whole house itself, from the foundation to the windows, including mentorship, and how medicine is built, how medical education, nursing education, PA education has been structured so that it is standardized test-based, which often is not a measure of privilege rather than competency. the biases in mentorship, preceptorship. Who are you recommending for an award? Who are you spending more time with? What kind of advice are you giving to a white student versus a Black student? And this whole allostatic load and the concept of this experience of discrimination and mistreatment is effect on students' performance. And so with that, I want to transition to cost. What is the cost of attrition in your respective profession to both to the students, to the communities, to the profession itself, to society, any of those broad stratas?
Yeah, I mean, thanks for thinking of cost in this really like broad way, right? Because I think, the most profound perhaps cost is really the cost that we're talking about in terms of like humans and continued health and racial and other inequities. Like we know that inequities cost, like actually like financially, the healthcare care system, I don't know, to the tune of like several $1 billion a year, right? So yes, there's like that financial cost, like not reap and value and richness of and strength of a diverse health workforce. We know that those are, a diverse health workforce is a key strategy for decreasing health inequities, not only because it's like, providers of color are more likely to treat communities of color, but there's new, like ways of thinking and just new ways of operating and connecting with people that we bring to that environment and then we bring to the educational spaces. And you look at so if you look at the last, I don't know, like 2+ maybe 3+ decades, and despite like hundreds of millions of dollars of investments made going into diversifying the health professions, not only have we not changed health outcomes, we really haven't changed the face of health professions at all, right? Like, I mean, perhaps there's been like single percentage point changes here and there, but overall, when we're talking about like BIPOC folks in the profession, we're like at the same as we were, 20, 30 years ago. And the cost is like to the community, the cost is to our future, the cost is to our children, the cost is to all of us. And there's no, like dollar amount to like wrap around that other than like, we need to continue to like dive into these spaces to, idea generate and problem solve together.
I often frame this question. I'm glad that you asked the broader question of cost. The first thing I say is why equity and inclusion are better concepts than equality is that the United States ranks some low place across the world in terms of health outcomes. That's a huge cost. Yet the cost is like $6,000 for developing nations where they have better health outcomes. And those generally are norming on white males. So I don't want to be equal to a white male. I want a better health outcome. And so we need to look at the cost of a system that is not functioning well. It's the first thing. The second costs are for most of the students that we work with are very upset about the curriculum because they often are being taught this very toxic white supremacy education that they're having to be tested on something that they know inherently in their spirits is wrong. So for example, there's a study now out that was put in Forbes by Catalyst on colorism in the workplace, that the darker skin you are, the experience that you have in the workplace is, in terms of racism and mistreatment, and is highest. Catalyst article on colorism, texturism, around issues around hair, of not looking like the Victorian image of Florence Nightingale or whoever. And so that curriculum costs a lot, because we're teaching, we're miseducating. That's Du Bois, isn't it? Is it miseducating? Carter G. Woodson. We're miseducating, right? Our young people. And so it's the same kind of, so my students often say, why would I have to sit in a classroom where everything bad about people of color, we have the highest rates of this and the highest rates of that and the highest rates. And here's a country that can shut down in 2 weeks for COVID and can't figure this out, or can put, and I'm glad Biden went to Ukraine, but can get Biden in there and nobody knows he's there, and we can't figure out how to reduce diabetes, hypertension. What is wrong with us? And so what also happens in this cost is distrust of the health system. The growing number, by 2045, the majority people will be all of these different previously underrepresented groups, and the health and cost of not being prepared to treat our diverse needs is overwhelming. We see patients, because they don't trust us, don't trust the system, delaying getting prescriptions and medical care. Thank you, that's the article. That they adhere less to medical records. I'm not gonna, my daddy would say, they say, Mr. Coleman, did you take your medicine? Daddy would say, yes, he didn't take it because he didn't trust them. And therefore the outcome of our communities based on the lack of trust, because the science is wrong. The science is wrong. I'll stop here by saying, I love my watch. I use this Apple Watch as an example. And people run around talking about algorithms, which are the same things that we use for normal lab results and abnormal. And so about now a year ago, Apple sent me a note and they said, what's your skin tone? You know why? Because the LED light could not read me, could not read. I had to do, it was one of the health things on here. It kept giving me an error because it did not know, because it had been normed on a fair-skinned person. This is the science that we're using to treat people. And the science, and we see it in maternal child. Why is Serena Williams, why a wealthy woman, a well exercised, an athlete, why did she have complications? Because our science is wrong. And then we have the nerve to teach our young people that faulty science. So that's a huge cost, let alone, and I said I would stop, but let alone the fact that we recruit students from low-income communities, from first-gen communities, and their families put all the money and resources in, and then we kick them out. And they don't have a degree. And if you come out without a degree, you'll never be able to pay the loans back. You'll never be able to take your family to the next level. The costs are overwhelming. And I think we should just let everybody know that Diana's internet was, she was on her hotspot. It probably got too hot.
Yeah. Thank you. When we look at the costs, and I think we've covered the various, levels, from the big macro picture down to the individual family and person, because I think that's one that I don't think the institutions even pay attention to the way they should. Is if you put somebody in here and then you kick them out, you've actually denied them the opportunity to, for many of us, move to a more secure economic level and class and bring our families with us. And so I think that we've kind of covered all of that. I think one of the things that's a cost also is it denies our students, their classmates, it denies their faculty, it denies the people in the team to learn from them. It might be a hard lesson for them to learn, but it denies them the opportunity to learn from them. And if you really think about the work around health disparities, it's the people who struggled through systems 20 years ago or 30 years ago, who then became researchers and said, there's something wrong with this picture. I'm going to do something that began to bring that information forward. So we're actually denying the ability to change and rebuild the system down the road by eliminating people out of our training programs.
Thank you. And that was very important and sobering, because there's so much that is lost with attrition, especially from attrition of marginalized students. I want to end on a kind of positive notes in terms of what work have you personally taken on to mitigate these disparities in attrition and reduce attrition rates in your respective profession for students?
Well, I could probably talk. Go ahead, because I could talk an hour. No, you go.
Well, I'll start with my institution. We have, really, first of all, we've declared ourselves as a school of medicine, as an anti-racist school. And to do that, we have built systems within the school of faculty members. I'm a member of one of the, our steering committee. And, we've since then have created diversity officers in each department with specific tasks, including, how people look at recruiting faculty, and then begin looking at systems within their programs, and their departments. I think some of the things also is, how do we change the curriculum? And so when people do show up, that they actually feel like, you're not talking about them, but you're talking inclusively. You're talking a way that people can learn from them, and that we're not stereotyping our folks. And so we actually have come up with platforms, and this is how you design a case. This is how you use examples and cases and tests, and those kind of things, and to begin to have conversations in our programs that happen around race and gender and privilege and so forth. And so so people can feel part of having that conversation. So that's one piece. I think the other parts are things like working with educational learning specialists, and not thinking just because you have this health education information that you are a specialist in learning, and that you know everything about how people learn and so forth. So I think that's one thing. We have pushed in our profession, so our professional organization, so we now have an accreditation standard for PA programs that holds the institution that sponsors the program responsible for giving support around diversity and retention. So programs have to now show that they have efforts, and they evaluate those efforts around retention. It's a new standard, so I can't give you the results of it. It'll take me another 10 years to have that. But I think that is one of those things. And then I know our professional organization has done things like made it part of strategic plan, get our, try to line up the mission and create resources for our members. Including a toolkit that our diversity inclusion mission commission has put together for programs to then have a roadmap of how you can, not telling them everything to do, but how you can then design things, implement them, and evaluate them as you move forward. So things like mentoring programs, building faculty, because having somebody look like you is really important when you go to school. And so and not just one. I think that's the other thing in any program. It's not just one. It's kind of like, I don't know if you know about the the Posse program where they send kids from the same neighborhood to the same college, so you have support when you get there. It's the same idea. So those are a couple of ideas that I know I've been a part of.
Well, I can only point out my successes. Some are here in this space. Dr. Dan is an example of the kind of success that we can achieve, that we never lose our support. I don't know, Dan graduated, I don't know, 90 million years ago, and we're still connected, and we're still on the front lines doing the struggle, knowing that this is a protracted struggle, that this is not a 4-year occurrence. And so looking at and lifting up examples of all of you who have made it through. Lauren Underwood, Congresswoman Lauren Underwood, comes right out of our Genesis program, who right from the beginning said she wanted to do policy. Being able to support associate deans of nursing schools and chief executive nursing officers in the largest state with the largest number of nurses in our union in California. On this line, I pointed out my own family member, Dr. Jade Burns, who is part of the Posse program, so that we stay connected, that we're able to look at programs that have been in existence. One of the things that, and we only have like 4 minutes, but the Genesis Project is a project that began somewhere around the turn of the century, 1999, and into the thousands. And what we did, and Dr. Jade here, and through the work of people like Dan, we brought in middle school and high school students to introduce them, because many of their counselors were telling them if they were interested in nursing, then they would put them in vocational training and take them out of math and science, or say that they weren't qualified. So we take them through middle school. For students that were looking at coming into the undergraduate program, because of Dr. Jade, we were able to create and fund for years a 6-week residential program to do early introduction to the campus so they could learn how to navigate the system, the little basic things like, what is the course management system? Where do I find my books? All these, where do I get the resources? So provide resources and having people on the ground. And then, like I said, we had peer facilitated study groups. We taught them from the beginning, Dr. Howard, how to take those tests, and that it wasn't them, that there was a formula to doing it, that they could learn how to be successful, and also making sure that we dealt with their social issues. I know I'm running out of time, but this one case was of a student. She was the first generation of her family, a Hispanic student. Her mother later said to me, Dr. Coleman-Burns, I had no idea what this higher education was. And so we brought her in the university in a summer program. And because it was the first time she was away from her family, by the time she entered the first semester of nursing, she had already failed 2 courses. And so having to work with the university to make sure when they bring our students in to these programs that we are guiding them and making sure that for the health professions, nursing has an undergraduate degree. So for the health professions that we're able to support, for the graduate students, just meeting basic needs around family and religion and culture, hair, what do I do with my children? These are all the things that in Genesis we tried to do, and we supported them, and we worked on the curriculum, and we worked on to intervene when students were being, Diana, dismissed, to step in, to have someone to take the risk, and then to work with graduate students in their research, so that one of my doctoral students, back in the day, you weren't supposed to only look at Black women. We had to fight for her right to research hypertension in Black women without comparison. So changing the science and being able to support the work of these geniuses, and never give up.
I know we're at time. I can quickly chime in here. And I know, like earlier we were talking about the house being on fire, right? This is my son, Camilo. And, I think about where do you go, right? We've created a reporting system and learners to share, like, okay, you've had these moments of harm, come and it's really earn the trust. The very institution that burned them, so to speak. But we've really created, I think, a trauma-informed approach that is really around like building trust, building relationships, and ensuring that people know that there are options. Like, we don't do anything without consent. Like, we're not going to do anything that would make a learner feel uncomfortable about how we can follow up. And I'll just do a quick shout out, because I know that one of our team members is here, Brenda Loya. So thank you for all the work that you do. But it's I think like things like this that we're doing, that we can like address the incident, like at the individual level, but also then like really build this or paint this picture in which we can better understand like what is happening in these learning environments, and how can we really create some intentional awareness and skill building education for people to engage in. And so, like that's a little bit about kind of what we've been doing. And I just want to also, I'm going to try and throw in the chat. Sorry, my internet is really funky here, but there's a couple of frameworks that we've really been using. I'm not sure if y'all are familiar with Dr. Loretta Ross and the framing of really like calling in versus calling out. Like calling out being really like about shaming, and that's not going to get us where we want to go. And so how can we be better at calling people in and learning from moments of harm. And then I'll just maybe end. I know we're a couple minutes over time, but I know, like, I think, this is a lot. It's a lot, and it's hard to think like, the house is on fire. Perhaps it's even like the foundation, perhaps it's the street or the, entire city. I don't know. It feels like that sometimes. And I guess, I would just say like what helps me sometimes and like get through that is really just like taking a moment, right? Like acknowledge where we are, but also acknowledge where we come from, right? Like we are a resilient people, and while we shouldn't have to be, it's not fair, it's not just, but like we think of our ancestors who are monumental, right? Like they are giant. And so I just say, like to all of us, like you, and we stand on the shoulders of giants. We will like get there, right? And it's slow sometimes, and it's difficult and it's tough, but like this is it, really building the like revolutionary love. That's what I'm here for.
Thank you. I love that revolutionary love. And I think we have created a community, everyone in this Zoom who attended today, as well as, our support system, our friends, family, and loved ones. And so, yes, thank you so much to our panelists, Dr. Straker, Dr. Coleman-Burns, and Deanna, for your time, for your thoughts, your insights sharing. I think we have a lot of work to do, and a lot of things to advocate for as well. And for the students on this Zoom, you yourself is the revolution, and so please take that deeply and strive on. And thank you for joining us today. And I hope everyone have a lovely evening.